Hello? Are you guys able to hear me?
Yes.
Okay, perfect. So today we are going to start our pathology section. Okay, let me just share my screen. Can you guys just see my screen?
Yes.
Okay, perfect. So let's start our pathology lecture. So the first lecture which we are going to take is oral cavity. So we'll be starting from oral cavity. We are going to discuss different pathologies associated with oral cavity, and further we'll be moving down to your alimentary canal. Okay. So the first pathology which we are going to discuss is aphthous ulcer. So can you guys just tell me what is aphthous ulcer? I think all of
Autoimmune
Oral.
disease.
Also in the mouth.
Yes.
Mhm.
It forms inside the lips and the mouth, and it's an autoimmune disease, very painful in nature.
Okay, perfect. So, like, everyone would have experienced this aphthous ulcer. It's a common occurring in oral cavity. So, basically, it presents as a painful superficial ulceration of oral mucosa. So, like, the main factors which contribute to, like, formation or causing of this pathology are going to be your stress. Like, whenever if someone is in stressful situations, so they are more commonly going to have aphthous ulcers, right? So the presentation is very important, which you guys should just keep in mind. So it's going to present as a painful, superficial ulcer of your oral mucosa. And the main eliciting factor behind aphthous ulcer is basically your stress, right? So it's basically stress induced. Okay, what else? The characteristic features are going to be like, you guys might have like seen a picture. It's a common occurring. So basically we have a grayish base and erythema surrounding that ulcer, and that's simple. Okay, so the next pathology which we are going to discuss is squamous cell carcinoma, right? It's going to be a high yield topic for today as well. Squamous cell carcinoma, right? Before discussing squamous cell carcinoma, let's discuss some of the concept of cancer. How do cancer occur at first place, right? So all of you are aware of the fact that cancer is basically an abnormal growth of your cells, right? So whenever we have an abnormal growth of your cells, it basically leads to cancer, right? And cancer further can be like classified as a benign or whether it's a malignant. Benign means that it's going to be like, well circumscribed. It do not have ability to invade, while malignant cancers do love to invade, right? So it's basically abnormal cell proliferation, right? Or rapid growth of or abnormal cells proliferation. So can you guys just tell me what are the main causative causes of having squamous cell carcinoma or having abnormal growth? So what do you think?
Smoking.
Smoking,
Mhm.
HPV,
Okay, so let's
Alcohol.
discuss it. Okay, perfect. So let's discuss it in a generalized way, right? I don't want you to just tell me the exact causes, right? Like generally, like for example, if it isn't, let's suppose, present within your oral cavity, let's suppose if it's a cancer of any other organ. So generally, can you just tell me what would be the cause of the cancer?
Chronic irritation.
Chronic irritation, perfect. Chronic irritation, right? Like as we discussed that smoking is the leading cause of lung carcinoma. So the generalized view behind that concept is that smoking basically is a chronic, chronic behavior, I would say. And this chronic behavior of taking irritants for such a long period of time keeps on irritating your mucosa, and irritation in turn can lead to cancer. What else? Mutations, right? If we have, like, let's suppose mutation within the genes and it turn on certain genes and we have abnormal growth, it can also lead to cancer, right? What else? What else do you think? Yes. Any idea?
Viral infections.
Okay, viral infection, yes, it can. Like some of the virus, again, that can, they can involve your genetics, they can take over the molecular machinery, they can just induce mutation, and in turn it can lead to abnormal growth or cancer. Another thing, if you just know that normally our cells keep on turnover, right? As they age, normally we have mechanism for those cells to remove them, right? So for example, if those mechanism which removes your worn out or older cells, if they fails, again, if you have no one to clear out cells, again, you're going to have abnormal growth. It can lead to cancer. Can I say that?
Yes.
Perfect. Okay. So the squamous cell carcinoma, which we are going to discuss, basically it's a malignant neoplastic condition, right? So it's a malignant cancer. What do we mean by malignant? You already know it tends to spread, right? It tends to invade the local structures. Okay. So remember, before getting like a cancerous condition or before getting squamous cell carcinoma, basically intermediate, we have a a form of cellular abnormal growth that is known as dysplasia, right? We have dysplasia. Okay, we have some terms, we'll be discussing that in our general pathology, that is dysplasia and metaplasia, right? So you guys are going to be telling me what's the idea of dysplasia, what is dysplasia, what is metaplasia, what's the main difference between dysplasia and metaplasia? Anyone?
I think in the metaplasia, what was happening, for example, we have Barrett's esophagus, like one epithelium changing into another, but it is not cancer. It is not cancer one, yeah. And for the dysplasia, when there's a change, it is a precancerous form, like
Precancerous. Perfect. Perfect. Okay. So basically, metaplasia, we use the term metaplasia whenever, like, for example, as Dr. Muskan gave us an example of like Barrett esophagus, which we'll be discussing in a while. What happens, basically, the types of cells are changed, right? Like, for example, if we have an individual, he's having chronic GERD, right? Gastroesophageal reflux disease, right? And chronically, what happens, his lower esophagus is going to experience, it's going to come in contact with a lot of acids, right? Are you guys getting me? If we have an individual, he have GERD, gastroesophageal reflux disease, right? And the acid content is going to be like coming in contact with the lower third of esophagus, right? So what this esophageal cells would do, it have a stem cell. These stem cells, okay, normally there are squamous cells present, right? And normally within the within your stomach, we have columnar cells, right? So as the lower 1/3 of esophagus keeps on, like as the acid keeps on irritating this portion of your esophagus, so what happens that these stem cell will transform itself from squamous cell to columnar cells. We need this transformation. Why? Because our stomach, or sorry, our esophagus have to bear that stress, bear the stress of acid. So in order to bear the stress of acid, it must change its cell type, that is from squamous to columnar. And columnar cells can easily withstand the stress, right? They can easily bear it, because in the stomach, you guys can see columnar cells can bear acids. Is that clear? Hello?
Yes.
Okay. So metaplasia simply is changing of cells from one type to another type, right? And metaplasia is, okay, is it reversible or irreversible? What do you guys think?
Reversible.
Reversible. Perfect. So if the GERD is treated, like GERD can be due to a lot of reasons. We'll be discussing, one of which we discuss hiatal hernia, right? If the hiatal hernia is corrected, what happens again, these cells which have been transformed to columnar cells will come back to squamous cells, right? So it means it's reversible. But in case of dysplasia, it's basically due like an unorganized growth of cells, and it's a precancerous form, right? Precancerous. Like, for example, if we have chronic irritation, right? So chronic irritation before transforming into squamous cell carcinoma, it have an intermediate, dysplastic form. First of all, the cells are going to become dysplastic. That is unorganized growth, right? And then these dysplastic cells are going to be transformed into squamous cell carcinoma. Is that clear?
Yes.
No? So it's a precancerous form. And
Yes,
what's
clear.
the difference? Yes. And what's the difference? Dysplasia is irreversible, right? It's irreversible. Okay. What do you guys think? Dysplasia is reversible or irreversible?
Irreversible.
Irreversible. And poorly
Yes,
differentiating.
Yes,
Poor
and poorly
differentiation.
okay. Yes, and it have poor differentiation. That is, the cell types are going to be like, disorganized, right? Okay. So we were discussing squamous cell carcinoma. Till now, we know this is a cancerous condition, and there must be some reasons of having, there must be some causes of having squamous cell. Either it can be chronic irritation, it can be mutation, and we already know before getting into squamous cell carcinoma, the cells must be dysplastic before, right? You must have a cancer or precancerous form, that is dysplasia, right? Is that clear?
Yes.
Yes,
Okay.
sir.
So in case of squamous cell carcinoma, which here we are discussing, the dysplastic form is going to be called as leukoplakia, right? Leukoplakia. What is leukoplakia? The term leuko means white, right? As we know, leukocytes, they're white blood cells, right? So before like having squamous cell carcinoma, for example, if you have an individual, we have chronic irritation, we do some examination, right? And we just see some white plaques. So simply one of differential which you will be thinking of that it could be dysplasia. It can transform to squamous cell carcinoma, right? Hello?
Yes.
Yes.
Okay. So leukoplakia is basically that precancerous form, dysplastic form before getting into squamous cell carcinoma, leukoplakia, right? Okay, there is another term used that is erythroplakia. What do you mean by erythroplakia? Okay, what do the term erythrocytes for red blood cells, right? So red appearing plaques. Can I say that?
Yes.
Okay.
Yes.
As we know that the cancerous cells, they're like, highly aggressive cells. If they're malignant, they would tend to grow a lot. They would tend to invade. They would tend to spread. It means they need a lot of blood supply, right?
Yes.
Yes.
Yes, for their growth, they do need blood supply, right? They need a lot of blood. So leukoplakia can be like, for example, if someone is getting squamous cell carcinoma, first of all, he's going to get leukoplakia, which is a dysplastic condition. And another intermediate step would be erythroplakia. That is, the leukoplakia is going to become more red. Why? Due to presence of a lot of blood vessels, it would appear red. So if I ask you a question, if we have an individual, two individual, in one individual, I just found leukoplakia. In another individual, I found like I see erythroplakia, let's suppose, right? The red plaque. So what do you guys think? Okay, this is individual number 1 and individual number 2. Can you guys just answer me which individual is close to get squamous cell carcinoma? Individual 1 or 2?
Second. Oh, one. Red one.
Second one. One.
It's erythroplakia.
Yes, erythroplakia. Perfect. Because it already have got its blood supply and it's likely going to be converted into squamous cell carcinoma. Is that clear? So for the squamous cell carcinoma, okay. But another thing which you guys should just keep in mind, whenever you see white plaques, you directly cannot say that, yes, it's a dysplastic condition. You also have some differential as well. First of all, if we see white plaques, what we are going to do, we are going to take a tongue scraper, right? Tongue scraper, simple. And we will just try to scrape off the leukoplakia, right? Or the white plaques. Simply, if you, on examination, you see white plaques, you just check a tongue scraper. If you cannot scrape off the white plaques, it's leukoplakia. If you can scrape off the white plaques, it's basically oral candidiasis, right? Remember?
Yes.
Oral thrush. How do you get oral candidiasis? You already know. Individual having asthma, taking glucocorticoids, we are decreasing the immunity within the mouth, in simple words. And you have the candida would just, like as an opportunistic infection, it would just cause oral thrush, oral candidiasis, right? So whenever you see white plaque, first of all, what we are going to do, we are going to take a tongue scraper, we are going to scrape it off. If we can scrape it off, it's oral candidiasis because leukoplakia cannot be scraped off. It's firmly attached to your tongue. Is that clear? Hello?
Yes.
Yes.
Okay, perfect, right? So this was all about squamous cell carcinoma. Let me just tell you, okay? I'll be just reviewing it and you should just keep in mind. So it's basically a malignant cancer, we know that. What are the factors which keeps on irritating the mucosa in turn leading to squamous cell carcinoma? Tobacco and alcohol use. As they are chronic behaviors, chronic irritation is going to cause squamous cell carcinoma. Is that clear?
Yes.
Okay. Before getting into squamous cell carcinoma, we need dysplasia. Which kind of dysplasia? Leukoplakia. But if we have white plaques, we're going to take a tongue scraper. If you can scrape it off, it's not leukoplakia, it's oral candidiasis. If you cannot scrape it off, it's basically leukoplakia, which is a dysplastic condition which can likely be converted into squamous cell carcinoma. It can likely be transition. Simple, right? Okay. What else? Leukoplakia is further going to be converted into erythroplakia, having a lot of vascularized vessels appearing red, which is more close to squamous cell carcinoma. Is that clear?
Yes, sir.
Okay, perfect, right? So this was all about squamous cell carcinoma. Let's discuss some pathologies of your salivary gland, right? Okay. Salivary glands, okay? So As we all are aware of salivary glands, basically they're exocrine gland, they make saliva. We have different major and some minor salivary glands, that is parotid, submandibular, sublingual, right? So all of you guys are aware of that, right? So let's discuss some of the pathologies. The first pathology which we are going to discuss is mumps. So you guys already did micro, and I think you guys already have idea of mumps. What are mumps? So you guys are going to tell me. Yes.
It's an RNA virus.
Okay, perfect. RNA virus. What this virus would do?
Inflammation of the
parotid
gland.
gland.
Okay,
Yep,
which gland?
bilateral
Which
parotid.
gland? Perfect. Bilateral parotid glands. What else?
It's
Orchitis, right?
orchitis
Orchitis.
enteritidis, yes.
Yes. If you
And-
guys have seen the picture of micro, there is a picturized. There is a person who is just hitting mummy, and that picture, if you just have in mind, so it would be quite easy for you guys to remember, right? So an individual is going to have orchitis, that is inflammation of his testes, right? What else? He can get pancreatitis, right? He can get septic meningitis, and if we have pancreatitis or in a parotid gland environment parotitis, so in that case, the serum LMLase is going to be increased. We already know that. An important point to keep in mind: if the teenagers get this, there is increased chances of sterility in future, right? It can damage the structures, and in future, this individual cannot reproduce. Is that clear?
Yes.
Okay, perfect. Then we have a small term that is salidinitis. So what do we mean by salidinitis? The idea is very simple. Whenever we get inflammation of salivary glands, it's basically known as salidinitis, right? So we already know that there are exocrine glands, we have ducts, for example, if this is our gland. So how do we get inflammation or infection or inflammation? That's very obvious. If something leads to closure of these ducts, again, we have stasis. We know the concept. Stasis can lead to increase, like growth of bacteria, increased growth of foreign, pathogens, which can in turn lead to inflammation, right? And the most common bug which causes inflammation of your salivary gland is Staph aureus, right?
Yes.
So how do we get obstruction? We can have stones as well, right? Sialolithiasis. The term stands for having stones, small stones, which can obstruct these ducts, in turn get inflammation. Is that clear?
Yes.
Okay, perfect. So let's discuss some of the cancers or some of the tumors which occur in salivary glands, right? So the first one which we are going to discuss is pleomorphic adenoma, right? Pleomorphic adenoma, right? So as it is adenoma, it means it would be a benign tumor, right?
Yes.
Yes.
Okay, it's the most common tumor of your, keep that in mind, right? And I just told you that you must know the common tumor, the common pathologies, and like, for example, the dilated cardiomyopathy. As I told you, whenever you are confused in a question, just go for your commonly occurring bug, commonly occurring tumor, and things like that, right? So you should just keep in mind. Pleomorphic adenoma, the most common tumor of your salivary glands, okay? So as it is benign, so all of the features are going to be of a benign tumor. What are the features of benign tumor? We already know that. Benign tumors are mobile, right? They are mobile tumors. They do not invade. They are a well-circumscribed mass, right? They are going to be painless. Why they are going to be painless? Because benign tumors do not invade. So for example, it's basically a tumor of your parotid glands, right? Parotid glands. And we know from the anatomy that in the parotid gland, basically our facial nerve passes, right? So if it's a benign tumor, it won't invade. It means you won't be having pain. That will be painless, because once this tumor invade your facial nerve, then we are going to experience severe pain. Is that clear? Hello?
Yes.
Okay, so it's most common. It's a benign. If it's benign, it means it's mobile, it's painless, well circumscribed mass at the angle of jaw. Okay. Okay, what else? That it can really transform into carcinoma, and we do not have facial nerve involvement because it's benign. That's all, right? So it's basically a tumor of some stroma that it would consist of some cartilage, some epithelial tissue, and it basically occurs in your parotid. Is that clear?
Yes.
Yes.
Oh, perfect. So the next tumor, which is the second most common benign tumor, is going to be your Warthin tumor. So what is Warthin tumor? We already know that it's the second most common tumor of your salivary glands, and it's going to be like a benign again, right? If it's benign, would we be seeing any pain? Would we be experiencing any pain?
No.
No, it would be painless. Perfect. But here the things are a little bit different. Basically, this tumor consists of a lot of lymphocytes plus germinal centers. You guys can just see. Normally, in the salivary glands, we do not have lymphocytes. We do not have germinal centers. Where do we have germinal centers and lymphocytes? Where do we get that? Where do we found lymphocytes and germinal center normally?
Follicles.
Lymph nodes.
Lymph nodes. Perfect. Lymph nodes. It means that seeing these tumors, seeing the the things or the constituent of this tumor, it means that it's something like similar to lymph nodes, right? So the idea here is that how do one get what in tumor? Like during your development, basically lymph node keeps on separating from these structures, right? From different structures, from your pharyngeal arches. So sometimes what happens, there are some remnants of, sometimes the lymph nodes tissue cannot entirely separate. And some remnants can remain within the saliva, right? Salivary glands. And those remnants of lymph nodes can develop tumor. That is going to be your Wharton. Is that clear?
Yes.
Okay, perfect. So it like almost always arises in your parotid as well, right? So let's discuss the last and malignant tumor of your salivary gland. That is going to be mucoepidermoid carcinoma, right? Mucoepidermoid carcinoma. If it's carcinoma, we already know it's a malignant tumor, right? For the malignant tumor, we already know that it's going to invade. If it's going to invade present in the parotid, it's going to irritate your facial nerve. So you guys are going to be telling me, would it be painless or painful? Painless or painful?
Painful.
Painful due to facial nerve involvement. Perfect, right? What else we are going to see is going to be malignant tumor, and what would be like the molecules, or what would be the constituent? You can just see the name, mucoepidermoid. It means you'll be having some mucinous cells and some squamous cells. Epidermoid stands for epidermis, again having squamous cells, right? So this tumor would be consisting of mucinous plus some squamous cells. Is that clear?
Yes.
Yes, sir.
Right? Malignant. Perfect, right? So this was all about our oral cavity. Let's move towards our esophagus, right? Esophagus. So we already discussed one of the pathology, T. fistula. I think we don't have to revise that, right? The most common variant and everything, T. fistula, right? Hello?
Yes, right.
Your fistula, perfect. So let's move to our next pathology, that is going to be your esophageal web. Can you guys tell me what is esophageal web?
Constricting, narrowing or constriction.
Okay, so esophageal web, like we already know that we have different layers of your esophagus. The first layer is going to be your mucosa. So sometimes what happens, this mucosa protrudes outward, right? So it's basically a thin protrusion of your mucosa like that, okay? So, and this structure is simply known as esophageal web. Simple, esophageal web. So if someone asks you what is esophageal web, it's a thin protrusion of your esophageal mucosa, right? And especially in the upper esophagus, right? Okay, what's the problem if someone is having esophageal web? The problem is very simple. If someone is just like, taking some hard food, right? Or improperly chewed food, so he would be experiencing this dysphagia, right? Because it's thinning the overall diameter of your esophagus. Can I say that?
Yes.
What would be the presenting feature? Dysphagia for poorly chewed food. Another thing, if you have this obstruction in the middle of your esophagus, so it means, again, whatever food is coming, this food is going to irritate this place, right? Because we have an extra mucosal layer. So can I say that it can lead to somehow chronic irritation if you are just ingesting food again and again over this thin area? This food is going to chronically irritate your mucosa, and chronic irritation in turn can lead to squamous cell carcinoma. Can I say that?
Yes.
Yes.
Squamous cell carcinoma. So those individuals who have esophageal web, they are prone to have squamous cell carcinoma in their future, right? So we have a syndrome that is Plummer-Wilson syndrome. If you guys know that, basically we are going to see a triad of 3 pathologies in Plummer-Wilson. We'll be discussing that in detail in our ENT, basically, or in our future modules. That is, we are going to have three things in this syndrome: severe iron deficiency anemia, esophageal web, and atrophic glossitis, right? That is the epiglottis is going to become atrophic, and due to that atrophy of the epiglottis or glottis, we are going to see the underlying red, web of your blood vessels, red capillaries, right? So that's why it would just appear red, and we basically use a term that is beefy red tongue, right? For that, is that clear?
Yes.
Okay, perfect. So let's move to our next pathology, that is Zenker diverticulum, right? So most of you guys might already know that Zenker diverticulum. Basically, Zenker diverticulum. Okay, is it an example of a true diverticulum or false diverticulum?
False.
False.
False. Okay, what do we mean by true diverticulum and what do we mean by false diverticulum? And Meckel diverticulum is a true or a false diverticulum? You have a word
True. It's true.
true diverticulum. So what do we mean by true diverticulum?
All the
True
diverticulum
has
contains all
yeah.
layers.
Okay, perfect. Having all layers. Which layers? Just count
Mucosa,
that.
submucosa, and
Mucosa.
muscularis.
Okay, mucosa. What else?
Submucosa
Submucosa
and
muscularis.
muscularis.
Okay, perfect. Right. So basically, Zenker diverticulum is going to be a false diverticulum. That is the mucosa is going to tear off, like the membrane, or the muscle, the muscularis layer, and it's going to move out like that. Okay, inside your esophagus, basically you are going to have a diverticulum there, right? Diverticulum is simply an outpouching or an outgrowth, right? And as it is a false diverticulum, it won't be having the entire layers. It will be only having mucosa, right? That is tearing your muscular layer, right? Okay, so for example, if someone is having Zenker diverticulum, what would be the problems with that? The problems are going to be really simple. So the food can get accumulated within the extra outpouching. And if the food keeps on accumulating, it can lead to pressure of esophagus, which can lead to dysphagia, right? So the presenting feature would be dysphagia, obstruction, as well as halitosis, that is bad breath. This food here can rot, right? And it can give bad breath, rotted breath. Is that clear?
Yes.
Okay, perfect. So let's revise what is Zenker diverticulum. It's an outpouching of your pharyngeal mucosa. It's a false diverticulum. You're going to have a word MCQ on that. Okay, what else? It arises above your esophageal sphincter, right? And basically, what would be the presenting feature? Dysphagia, halitosis, obstruction. That's simple, right? Is that clear?
Yes.
Okay, let's discuss our next pathology. We already discussed it, if you guys remember, Mallory-Weiss syndrome. You guys are going to be telling me what is Mallory-Weiss syndrome. What is Mallory-Weiss tear? Yes.
It's when there is like a damage to the esophageal mucosa in the GE junction.
Okay.
Lead the longitudinal tail.
Okay. So, as we discussed, it's basically a longitudinal tear of your esophagus, lower esophagus, right? And how do we get that longitudinal tear? If someone is having severe vomiting, so that pressure of vomit can sometimes, tear your lower esophagus. And that tear is going to be in a form of, longitudinal tear, right? So that's simply known as Mallory-Weiss syndrome. In which kind of individuals we are going to be seeing this? That's obvious. Those alcoholism and bulimia, right? Because in those kind of individuals we have, they are more prone to have, forceful emesis, and in this way they can also develop hematemesis. If you have tear, this tear can lead to blood within the vomit, which is simply known as hematemesis. Is that clear? And we discussed one of disease, if you guys remember, and sliding hiatal hernia. There we are also seeing Mallory-Weiss tear, right?
Yes.
Okay, perfect, right? Okay, so the next pathology, which we already discussed, is esophageal varices. We discussed it in a big detail, if you guys remember, the portal hypertension and things like that. So you guys are going to be telling me that. What are your esophageal varices?
When there is dilatation in the veins, in the lower esophagus.
Okay, how do we get that dilatation?
Because of
portal hypertension.
Okay, actually we know that there is anastomosis between your two kinds of your venous system. That is your portal veins and your systemic vein. One of the anastomosis is going to be at your lower esophagus, right? So if someone get cirrhosis, if someone gets some liver pathologies, and due to that we have portal hypertension. So three areas we are going to see dilatation at three areas. One was at your lower esophagus, giving you esophageal varices, right? And what's the problem with that? They can bleed. that can cause hematemesis, and it would be a painless bleed, which in turn can lead to death as well, right? The most
Yes.
common cause of death in individuals who are having liver cirrhosis is going to be your esophageal varices. Keep that in mind. And what's the drug basically which we give?
Octreotide.
Octreotide.
Octreotide. Okay. Yes. Okay. So basically, we are going to give somatostatin analog. That's octreotide, right?
Somatostatin.
Yes. Perfect. Right. So this was all about your esophageal varices. Let's discuss our next pathology. That is going to be your achalasia, right? Achalasia. So basically, what do we mean by the term achalasia, right? Can anyone just tell me?
Without
Yes,
relax.
and there is a problem in relaxing the lower esophageal sphincter.
Perfect. Achalasia, it means no relaxation. Okay, there is difference between, like constriction and no relaxation, right? So what happens in achalasia, we do the lower esophageal sphincter cannot relax. So why can it not get relaxed? So for relaxation, what do we need? We need ganglion cells. We need some nervous supply or the mentoric plexus, ganglion cells of your mentoric plexus, which leads to this relaxation. Okay, so ganglion cells of your mentoric plexus are basically responsible for your relaxation purpose, right? So if we do not have these ganglion cells, it means we won't be having relaxation of lower esophageal sphincter. If the lower esophageal sphincter do not relax, so as we are just eating food, it would just keep on accumulating like that. You are going to have a funnel kind of structure, right? Because the food is going to build up here. There can be a lot of problems as a result of that. So first of all, it's basically due to lack of those ganglionic cells. How do we have lack of these ganglionic cells? It can either be idiopathic, we do not know the cause, and the secondary cause is basically due to trypanosoma cruzi. Remember Chagas disease, right? Hello?
Yes.
Okay, so trypanosoma cruzi or Chagas disease infection can lead to achalasia, right? So if someone is having achalasia, what would be the problem which arises due to this pathology? The idea is really simple. Individual is going to experience dysphagia because the food cannot enter your stomach. What else? If you have food there, it can lead to chronic irritation. Chronic irritation in turn can lead to squamous cell carcinoma, as we already discussed, right? What
Yes.
else? Food is going to be rotten there, right? It's going to lead to halitosis again, rotted breath. And barium swallow is basically important. Barium swallow study is important for diagnosing this disease. So barium swallow is going to give us a bird beak appearance. Simply, you guys can see it's a bird. It's a kind of bird beak, right? Like that, right? So for example, if you have a bird, you guys can see, right? There's a bird beak appearance at barium swallow, which is very hard yet for this to know, right? Okay, and increased risk of squamous cell carcinoma. The idea is clear. The food which is accumulating is going to keep on irritating your mucosa, and irritation, chronic irritation in turn can lead to cancer. Is that clear?
Yes.
Okay, perfect. So next pathology which we are going to discuss is gastroesophageal reflux disease, right? GERD. We already discussed a little bit in the previous topic, if you guys remember. So what is GERD? GERD is basically reflux of acid from the stomach back into your esophagus. How do we get this GERD? The idea is really simple. If this wall, the lower esophageal sphincter, isn't able to properly close, so as the stomach is contracting, if it isn't able to properly close, what happens? The acid is going to reflux back. Is that clear?
Yes.
Hello? And if the acid is refluxing back, okay, what are the risk factors? Alcoholism, tobacco use, obesity, like fatty rich diet, caffeine, hiatal hernia, if you guys remember. We discussed it in hiatal hernia, right? What would be the clinical presentation? Heartburn, like you can just confuse it with, like myocardial infarction, right? Is that clear?
Yes.
And like one of the differentiating feature of GERD and MI is going to be like the duration of pain, right? So the pain here is going to be like long term, right? Like more than half an hour, things like that. While in case of myocardial infarction, the timing is going to be like less. Okay, so this is like something which can be confused with myocardial infarction, because in that we already know we have a substernal chest pain. So sometimes it can be confused, right? Okay, if the acid content is coming back into your mouth, so the acid can erode your teeth as well, teeth enamel. So it can lead to damage of teeth enamel as well, right? And as we discussed that if we have long-term GERD, long-term regards of this acid, so this lower the lower segment of your esophagus is going to like undergo metaplasia. The cells are going to be changed from squamous cells to columnar cells, as we discussed, in order to withstand this stress, in order to bear the acid coming chronically. Is that clear?
Yes.
And once they transform, the squamous cell transform to columnar cells, now this portion of esophagus is going to be called as Barrett esophagus, right?
Yeah.
Okay, Barrett esophagus. Okay. As we discussed that normally the esophagus is basically lined by squamous cells. We do not have columnar cells, right? But in case of Barrett esophagus, in the lower third portion of your esophagus, we are going to form some columnar cells. Okay. The cancer which basically like the squamous cell carcinoma is basically cancer of your squamous cell. You all already know that. What's basically a cancer of columnar cells? Can you guys just tell me? Columnar cells have a lot of glands, right?
Adenocarcinoma.
Adenocarcinoma.
Adenocarcinoma. So for example, if I have an individual, let's suppose I just get biopsy and he have adenocarcinoma. So like it's simply you're going to think that, okay, adenocarcinoma is also always going to be in the lower 1/3 of your esophagus. And before developing adenocarcinoma in your esophagus, we need regurg, we need metaplasia, we need your columnar cells to be present. Is that clear? Because adenocarcinoma is cancer of your columnar cells, it's cancer of your cells who contain glands. Is that clear?
Yes.
Okay, perfect. Right. So if we have, can I say that adenocarcinoma is going to be always present in lower 1/3 of esophagus? Can I say that?
Yes.
Can I say that before developing adenocarcinoma, this individual must be having GERD? This individual must be having metaplasia as a result of that GERD. This individual must transform his lower 1/3 cells from squamous to columnar in order to get adenocarcinoma. Can I say that?
Yes.
Perfect. That's perfect, right? So, Barrett esophagus is basically metaplasia of the cells from stratified squamous epithelium to non-ciliated columnar epithelium with goblet cells. Goblet cells are basically those mucin-releasing cells, okay? Okay. So, esophageal carcinoma, right? This is going to be the last topic for today, and tomorrow we are going to start stomach. And, okay, so the last topic is esophageal carcinoma, right? So, as we discussed, in esophagus, we can get two kinds of carcinoma. Squamous cell, you already know the squamous cell carcinoma, and adenocarcinoma. But before getting adenocarcinoma, we must be having GERD, we must be having Barrett esophagus, we must be having metaplasia from squamous cells to columnar cells. Is it clear?
Yes.
And it would always be in the 1/3 because this acid, the reflux, can only reach 1/3 of your, it can only impact the lower 1/3, right? That's why we are going to see it in lower 1/3 of your esophagus. The idea is really simple. So the squamous cell carcinoma is going to be upper 2/3, right? The remaining portion is going to get squamous cell carcinoma because there we cannot develop Barrett esophagus, there we cannot develop, like the metaplasia. So that's why in the upper 2/3, we are almost always going to see squamous cell carcinoma. Is that clear?
Yes.
Okay, perfect. Okay, so how do we get squamous cell carcinoma? Again, the idea is really simple. We know the concept, chronic irritation. So what things can chronically irritate your esophagus? First of all, we know esophageal web. We discussed that, right?
Yes.
We discussed another thing, achalasia as well. Food accumulating, chronically irritating your esophagus. Chronic irritation in turn can lead to squamous cell carcinoma, especially in the upper 2/3. Is that clear? What else? Very hot tea. Very hot tea is also an irritant, right? So in Japan, basically most of the people who consume hot tea, like it's going to be considered as a chronic irritant of your esophagus. So they can also develop, squamous cell carcinoma. So before drinking tea, please take care of that as well. Okay. What else? Again, alcohol and tobacco. It can again chronically irritate your esophagus. The idea is simple: chronic irritation. Is that clear?
Yes.
Hello? Okay, what would be the symptoms? The symptoms are going to be like really interesting, right? So first of all, the symptoms would be if you have a tumor, if you have a cancer, a squamous cell, or adeno, the idea is very simple, it's going to lead to dysphagia. First of all, this individual complained that first of all, I had dysphagia to like solid food. And then as the time passes, even I couldn't, take liquid. So the idea is really simple. This is a So malignant cancer, as it keep on growing, it's going to obstruct your esophagus. Even an individual cannot even drink some liquid, right? And we already know the constitutional symptoms associated with your cancer: weight loss, pain, involvement of nerve, hematemesis, because it have a lot of blood vessels that can rupture. It can give you hematemesis. Is that clear? Hello?
Yes, sir.
Perfect. So this was all about today's lecture. Tomorrow we are going to discuss stomach, and day after tomorrow we'll be ending our discussion by discussing a lot of topics related to our colon and small intestine. Hope so you guys enjoyed, and day by day I'm just seeing very little participants coming into classes, even in the Discord server. Yesterday I just told you guys to be there on time. I don't know what's happening. Can you guys just please share with me what's the problem going on, so if we can help you solve that? Hello, Dr. Kenana, Dr. Daniela, Dr. Ramesh, Dr.
Yes, sir.
Harshini.
For me, it's
Yeah.
just that I work every day, so that's why my shift starts from 1 p.m. to 7.
Okay.
So, yeah.
Yes, Dr. Ramesh.
Yes, doctor. So yesterday I joined the discussion, but I think no one started, so I just left.
Okay, so please just continue your session there. And as you guys know that we have very less time remaining in the marathon as well, and I have dedicated Dr. Mahin as well. Those who are about to give the exam, soon we'll be starting our second phase. So just get prepared for that. And for okay, so we also have some announcement we'll just make in them in a week or so. So get prepared. Those who have booked their exam, please send screenshot to Dr. Hamza, and he'll just let you in the group. And soon we are going to start discussion there as well, right? So thank you so much, and please do take care of the participation. Please just join the classes, because we have a lot of people in the group, like almost 160, and we are just seeing like 40 to 50 students. So it's a kind of a sad moment for me as well, to be honest, right? Thank you so much. Take care of yourself. Focus on your studies. I'll be sharing the schedule in a while, and if it's feasible for you, so please just start your discussion on the Discord server, because I know that most of you guys have done your course. You guys are now pros, right? So you guys will be giving your exam in a while, but we have some students who are beginner and who need your help. So please help your mates as well, right? You aren't always there, so it will be quite grateful if you guys keep on continuing those sessions. So like it's helpful for a lot of students who are like a little bit weak, right? So for the pros like Dr. Ramesh, Dr. Abdur, Dr. Daniela, Dr. Kenana, Dr. Mariam, Margaret, please try to help your mates as well there. Okay, thank you so much.
Thank you, doctor.
Thanks,
Thank you,
Doctor.
doctor. Thanks.
Thank you. Have a nice day. Bye bye.
Yes.